Insignificant descentation occurs quite often in 25% of the cases, but clinically significant descentation occurs only in 3% of the cases. And most of the time, the presenting complaints are photopsia, glare and halos, post images, double images, photosensitivity, and there may be some related to the blurring of the vision, and the loss of contrast is one of the commonest thing. So this is a patient who had a pseudophakic patient, operated 8 years ago, maybe now more than that. And this was the picture. It was operated by me. At that time, foldable lenses were not so popular. The patient had pupillary capture. And after 8 years of the pupillary capture, also you can separate the bag. I can actually redial the lens. So I have seen that the separation of bag is possible irrespective of the time frame. And recently, so we put on a Hilon GV, and then anterior and posterior capsule were separated. And there was actually anterior capsulorhexis margin runoff at the time of surgery. That was the region of descentation. So you can put this lens back into the bag, but sometimes where the lens loop is there, there may be adhesions may be too strong, and you may not find enough of a space. And if you feel that the bag is not well centered when you place into the bag, then you can actually put into the sulcus, because this was quite a big lens. So there was no problem in placing this into the sulcus. So we tried to place into the bag, and once we found that probably may not center well over there, you can place into the sulcus. And then you constrict the pupil after putting the lens. So after putting into the bag, I was not very comfortable. So taken it out of the bag and placed into the sulcus. So now, in fact, you can dial the lens itself into the bag. And initially we were scared. Just recently I operated a child, nearly 10 years old, and the toric multifocal lens was placed. And after 4 weeks itself, there was a strong fibrosis. But once I went in, I found I can remove whole of the fibrous band comfortably without any problem and reposition the lens. So it is possible to remove this fibrous band as well. And posterior capsule is not as weak as we think it is. So this is the another patient. This was one-eyed patient, had a high myopia, and lens was subluxated down. And you can see the loop is somewhere coming out. So I didn't want to do the complete surgery. I thought, okay, it's a one-eyed patient. Why to do the massive surgery of doing vitrectomy and taking it out and place it again? So at that, just I put on one thread, one needle above the loop, one below the loop, and pulled it and fixed it onto the sclera. That served the purpose for the time being. If the other loop dislocates, then we will do the second surgery. This is a young boy, approximately 26, 27 years of age, operated congenital cataract, had a controlled glaucoma borderline, and the pressure was 22, 23 with the maximum medication. And there was a lens was into the anterior chamber, one loop behind, one in the front. So we thought we'll remove this lens first before doing any surgery for glaucoma. So we took it out. Whenever I want to take out the loop, I usually put one instrument below, one above, and pull it out so that it is guided well into the incision. So whenever you want to cut and remove the lens, so this lens was taken out. And then a standard scleral fixation of the new lens was planned. So after tying I used Prolene 90 sutures. So there were double arm, 2 Prolene 9 sutures were used in this patient. So both the sides, 2 needles were there. So we pulled out one needle. Same way, all the 4 needles were taken out. Initially, I used to put on a cross and then take it out and then tie the thread. So I found that tying the thread without needle takes a little longer, a little more cumbersome. So now instead of that, I use 2 sets of needle, because once the needle is there, putting into the hole of the scleral fixated lens becomes easier. didn't want to really do very massive surgery. Actually, trying to remove the adhesion and all those things cause a lot more inflammation. If the iris is stuck somewhere, and then I found even if you remove it, it gets stuck again. So it's better to cut it if you want to, but such an old adhesion, there's no point of trying to cut it and trying to place it over there. So the one thought, can we place this lens, lifting the iris and put into the sulcus? But so much of a fibrosis, I don't think it is worth it. So the lens was scleral fixated. Thank you very much.
Thank you very much. And faculty would like to share their experience in such situation? All the friends in the hall, would you like to have any question for Dr. Lal? Sir,
only thing I will like to talk over here, all those. Yeah.
No, please go ahead.
So only thing I will like to talk over here is that all of us should know IOL explant. Particularly nowadays we are using foldable IOLs, and if you are using multifocal IOLs, so sometimes patients may be very unhappy with the multifocal IOLs, and out of 100, 1 or 2 patients might be so unhappy that you need to remove it. So even I suggest all my residents, you put the lens inside the eye even without any problem, cut it and remove it, so that whenever you need it, you are confident that you can remove it. Because if you are not able to remove it and you feel jittery, then patient is on an offensive and you are on a defensive. So any patient is symptomatic, I tell them, you come, I'll remove it and put the next lens free of cost. So some of the patients could not adopt it. I had one patient which I removed after nearly 8 months of surgery. He tried to adopt it, could not. He had floaters, he was worried about that. Then he developed by the time ERM also. So with so many things happening, so we removed the lens, now he is comfortable. I had one patient who had the eye-hands lens implanted in one eye. He had minus 1.25 diopter of myopia. He had excellent vision, but he was not happy. I want to see at all distances. He actually researched everything, and then he compared VVT and synergy. Are we getting late?
No, please go ahead.
So I explanted. He went for the VVT in the one eye. Then he said, sir, iska vision intermediate is very good, but it is not as good as eye-hands had. Because eye-hands minus 1.25 was absolutely perfectly focused for near. So next eye I said, I'll put you the synergy.
Good.
And if you are happy, you choose the lens now you want. You have got the experience of all three. So you are happy with the synergy, I'll cut the VVT and put the synergy over there. If you are happy with the VVT, I'll cut this synergy and put the VVT over there, so you decide whatever you want. So after putting this synergy, he was very clear. He said, VVT is giving me clearer vision for distance than synergy, but synergy is very good for near. But with both eyes open, he was absolutely comfortable for near and distance both. So ultimately he was happy. He was very finicky type of patient. So if you have a confidence, or if you don't have a confidence in removal, then probably you have to not try to do all these maneuvers that you tell the patient in advance that I'm putting this synergy. If you're not happy, I'll cut it and remove and put on a VVT. So you need to know how to explant the lens as well.
Sir, I know you are a man of wisdom, so I would like to ask you some non-ophthalmological, non-technical question, social question. Sir, in such situation, if the patient is operated by somebody else, operated by somebody else, your colleague, not by you, sir, what will be your charges?
See,
how will you handle this part, financial part?
So far as any colleague is in trouble, I got no interest in charging any fee from the patient, whosoever he may be.
Okay.
And I request my colleague to pay for the material. I will not bother the patient at all. If he comes for the second surgery to me for the IOL explant, and if the colleague has talked to me, then 100% it is done free of cost.
So
but if he has not talked to me, then
it
is entirely a different matter. Because patient was operated somewhere else, he comes to me, and then I explant it, then of course he is mentally prepared for the full fee. But if some colleague has referred to me, I always tell them, some of the colleagues talk to me, so you send to me, I'll take care of it if you have got any problem. Either by convincing or taking the bold step. But if the colleague has not talked to me, then it is entirely a different problem.
Thank you, sir. See, there's another point, Shail. What he said, that never use any word like mistake, this or that, when the case is operated by somebody else.
Never.
And now there is another point that you don't charge the patient. If the colleague has called you up for the further this thing, I mean, all friends, no, it is what we do, that we don't charge, make the most maximum. At times it has happened, no? If our colleague has collected the charges, he will tell that, sir, those charges which I have collected will give to you. But let us not charge the patient extra. So that colleague, whosoever is charged, that money is transferred to you. I mean, the second
Whether they
survey.
transfer,
So
I
these,
think
these, sir, these
this
things
is
are very
a once in
important.
a year type of a situation, so I don't think that 10,000-20,000 rupees this way or that way or 10-15 minutes of your time really bothers us. So, but only thing, the decency and courtesy should be there. I mean, I had the doctors, patient has got, you put on the lens, patient has got 50 IOP for 1 week or 2 weeks, you are holding on to that patient, not referring anywhere, then patient comes to me. I call up myself, and then if you can handle, the patient needs explant, can you handle it?
Yes.
Yes. Then I go in, I ask him, he had put 2 IOL, they never informed me there's another IOL lying behind. I mean, so these type of colleagues are not welcome. I mean, when I'm giving a call, I'm trying to help you out, that I'm not criticizing in front of the patient. And this has happened twice. Another also, one of my colleague had a AP nuclear drop over there, and then I put in the lens, patient had a lot of problem, inflammation and not going. So I'm asking you, the lens is subluxated and you're not giving the right picture. So I mean, at least you tell me, sir, there is a drop over there. I mean, I'm giving you a call, you're not giving me a call even out of the courtesy being senior. I mean, we are such a level where the last thing on the earth we like to criticize anybody.
So that's why
So
in
we
such
go out of the way and then you don't even respond and tell it correctly. That's not on.
So in such situation, you have to handle the patient both way, medically as well as socially. Please,
And,
Rajiv.
That in any case we do. I mean, that's
another
a senior
important-
doctor's responsibility that, and we have got to set the right train for our
Colleague,
coming generation.
yes.
So
Please,
never
Rajiv.
ever, never
And
ever.
once it is operated by somebody else, somewhere else, which doctor you don't know, sometimes you are in a critical situation. Once you are going to operate, it is a complicated situation. You have to explain the pros and cons.
Yes, that
and
is true.
At the same level, you don't want to criticize the earlier surgeon. It is something like that. It is slightly, it's not in the place we are going to manage. But additional surgery has an additional risk.
Yeah. Thank you.
And sometimes when the colleagues, I mean, a lot of people have to learn. Once the patient was a post-LASIK patient, so she never wanted to put on a glasses. I suggested, okay, you can go for multifocal. And believe me, I put a lot of multifocal in post-LASIK patients. All of them are happy. I have not seen any patient cribbing about it because they are mentally tuned not to have the glasses at all. And then it goes to some doctor somewhere in the periphery of the UPSS. It's like a bomb, never get it done. I will never, it's a criminal. I mean, and why you have got to use such a strong language? Of course, I didn't put the multifocal in there. When she came back to me, I said, no, I'll put only monofocal. Because somebody has already poisoned your mind so much against the multifocal IOL, and anything goes wrong, then you will keep on saying that doctor has already told me, don't put it. So I said, I'm not going to put no multifocal in your eyes. So I think you should be very careful what you talk to the patient, not to poison the patient's minds and not put a suspicion on the integrity of the doctors in front of the patient.
Very true, sir. Sir, with your permission, we go to the next one, sir.
Yeah.